Yeah, and they're like, can't do that. Okay, let's do some ventricular dysrhythmias. Are we panicking?
Yes.
Yes, we are. All right, we're going to start with PVCs. What's a PVC?
Premature ventricular contraction.
Premature ventricular contractions. What happens with PVCs?
You have that.
Same thing that
Is
happened
it a
with
block?
PACs.
Like a block. You get excited.
You got excited. That was it. And your ventricles are like, boop. Yeah.
Yes.
Okay. So the ventricles are supposed to like wait for the atria. They could not wait. Okay. So they just had a little extra. Beep. Are we freaking out?
No.
No. What's the heart rate going to look like?
Higher.
I don't know though. It depends on how many you have, right? So it could be normal, could be higher, depending on how many PVCs. Some people just have like one and they're like, whoop, that was weird. You know, some of them have runs of PVCs. Got it?
Yes.
Okay. PRI, what's that going to look like?
0.12. Well, if they have an X, sometimes they wouldn't have a P, right?
Sometimes they wouldn't. Yeah. Yeah. Because the atria isn't either getting the time to, or how do I say this right? When the ventricles are going off an extra one, then which one do I?
Oh, okay. Do the extra ones have a P wave?
No, because it's just the
a
ventricles.
QRS by itself.
It's just the QRS by itself, right? So you can't really calculate that. Yeah, like turn it over and look at it. Oh, she already was. Cool. All right, so you can see that there is a P at the beginning, then a QRS, right? Then their T, and then whoa! I mean, that was a big one. Whoop! So how do I calculate that? There is no P. So
Oh, because that's the T?
Yeah.
Okay.
That's a T wave. So I can't, that's why it says that the PRI is absent, because
There is no P. Got
yeah,
it.
you see?
Mhm.
Okay. All right. The QRS should be normal though, right? Even if the ventricles are firing off abnormally, it should be still a normal beat. Yes?
Yes.
Okay. All right. The heart rate may also look irregular. Yes. Because, and I can't even say regularly or irregularly, because it's just going to all of a sudden pop off. That's why this looks weird. Like if you saw this, you'd be like, shit, that ain't right. Y'all would know, right? Like, yeah, you would know. Okay.
Whoa.
Yeah, like that didn't work out right. But you can see, I mean, obviously it's very exciting. Okay. Is this patient stable?
Yes.
Yeah. What are the causes of PVCs?
Excitement.
Stress, caffeine, anxiety, and your ventricles are just like, ah, yeah.
Yes.
Okay. Priority. What's the first thing you're going to do when a patient has PVCs? Find out why. Yes, I need to find out why. And then I just need to treat the underlying cause. If a patient has runs of PVCs, like they just have them, right? If they're having them in the hospital, what might I treat them with? Lidocaine. We're going to use lidocaine. Okay. You could also use amiodarone to send them home on, right? We don't usually send people home on.
Lidocaine.
Yeah, that wouldn't work out. And then if this is it's happening a lot, then you're going to give them beta blockers. Do you understand?
Yeah.
Okay. Next is V-Tach, big daddy, little daddy. Which one? This is a big one, right? Am I going to panic if they're in V-Tach?
Yeah.
Yes, I absolutely am. Okay. So their ventricles are going so fast that they don't have time to fill. So they might have signs of poor perfusion because their stroke volume is going to be so bad because their heart rate is so high. Clear?
Yeah.
Clear. So what's heart rate going to look like?
Very high.
Very high.
Or higher.
It has to be at least over 100. It can go usually up to 250. It can go higher than that. Okay. But by the time it goes higher than 250, they're usually going to go into VFib.
Okay.
Okay. All right. PRI. What's their PRI?
You don't know?
I don't know, because I can't even see a B wave. All I see are QRSs, but they're not pointed, right?
They're like mountains.
Mountains, indeed. Okay. So QRS is
Wide.
So it's going to be greater than 0.12. We call them wide and bizarre. If you ever see that on an exam, every nursing school in the history of all time, that's how they describe it. Wide and bizarre. Okay. Yeah, that sounds awful. So I actually wrote the word bizarre on there because they really like that word. Is this patient stable?
No.
I don't know.
Oh, you have to check.
Yeah, I have to check, right?
Yeah.
Because what's the first thing you do if a patient's in V-Tach?
Check for signs of
poor perfusion. So I'm going to check for
pulses,
increased capillary refill if their arms are cold and dead, right? Or if they're mottled. Okay. If they do not have signs of poor perfusion, then what am I going to do? I still have to do something, right? In this
CPR.
case, I have to do something, but they're stable. So I'm not going to start CPR if they're considered stable V-Tach.
No signs of poor perfusion.
They do not have, it really messes you up when I say it like
Yeah.
that. The patient is stable. The patient looks good. They're perfusing beautifully well.
Amiodarone.
You can give amiodarone or lidocaine. Those are the two drugs of choice according to ACLS. You with?
Yes.
Okay. If they are not stable, meaning they have very weak pulses, their cap refill is 6 seconds, their arms are cold and dead, what shall you do? You're going to start CPR. Is this a shockable rhythm?
No.
Yes.
What?
Yes. You can shock it. What can you not shock?
Asystole.
You can't shock asystole. I would not shock PVCs. That would be rude because you're already like over shocked anyway. So you can shock this rhythm because to shock something means like there's an abnormal electricity going on and I just need to fix it. And the reason I would shock this if they really are like practically dead. Y'all know V-Tach goes into VFib like that, right? If they're already having signs of poor perfusion, I've got to get them back on a normal rhythm. Okay. So if they are stable, which means no signs, which means that they are perfusing. Okay. Then I'm going to treat them with either amiodarone or lidocaine. If they are not stable, signs of poor perfusion everywhere, then I'm probably going to start CPR, probably going to, no, you are going to, and then they may or may not shock the patient. Okay. Are we clear? Y'all look what it looks like. This is, you can tell this from 122 miles away. You know exactly what that looks like. If all it is burp, 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 that's V-Tach and everybody knows that.
Okay.
Easy enough?
Yes.
Okay. While you have it turned over really quick, look at VFib. If it looks like somebody wrote it with their feet, that is VFib.
Chicken scratch.
Chicken scratch. That is exactly what it is. VFib. Are we panicking?
Yes.
Absolutely. We are panicking. What is their heart rate? It's really hard to tell. They may not really even have a heart rate per se, because in fibrillation, remember it's buzzing. Zzz, how much cardiac output do they have?
None.
No, not very much.
No.
Not, yeah, you're right. And they may not have anything. So yeah, we need to fix this immediately because they're getting no cardiac output. That's probably bad for their body. Yes, indeed. Okay. So what's their PRI look like?
You don't know.
I have no idea. What does your QRS look like? You do know. You do know, because if you look at this, those are QRS complexes, right? And they're very wide. Yes. They don't call them bizarre. They just call them, they're just longer, right? So it's going to be greater than 0.12. Okay. Is this patient stable? No, they're about to just go burp on you. So while we have the opportunity to shock, we're going to shock.
Yeah.
Yes. Okay. All right. So what do we do for VFib, by the way? Defib, VFib. However, be careful on exams, because if you don't have a crash cart readily available and the patient goes into VFib, you're not gonna be like, well, that sucks for you. Crash cart, you know, what are you gonna do?
CPR.
You're gonna start CPR until you can get a crash cart out there and you can defibrillate the patient.
So,
Do you understand what I'm saying?
Like, how would they word that in a test? Would they just be like, oh, you don't have the crash cart yet?
Yeah, just like a patient just came in onto your unit, you know, you just walk up to the patient and
VFib.
there they are. Then you're going to start CPR first, and then we're going to defibrillate the patient. Now, what causes a patient to go into VFib? Oh my God. Okay, if they have V-Tach. Okay, so can we?
That's fair.
All right, massive electrolyte imbalances, right? Especially potassium, could also be calcium, right? Because calcium is a little bit of heart, right? Okay. Drug use will do this, especially our stimulants. Like, I'm not talking about like caffeine. I'm talking about like the big uns, the big uns. Okay. Patients with severe trauma, you'll see them go into VFib. Like, I've seen this on TV a million times. Patient comes in, oh my God, they're in VFib. Yeah. But they also shock asystole on TV. So, you know, I know they always shock asystole, and you cannot do that. I want to be clear. Okay. A massive MI, patients can go into VFib because their heart's going to go faster and faster and faster to try to compensate. Yeah. Okay. Cardiomyopathies. What is a cardiomyopathy?
Muscle problem.
A heart muscle problem. Yeah. So if your heart muscle can't pump hard, then it tries to pump fast, right? It's gonna, yeah.
Yes.
Okay. So is the patient nearly dead?
Yes.
Yes. So you might want to call somebody, you know, like a code or something. Yeah.
Yeah.
Okay. So if they're in VFib, this is a code situation.
So even like you see VFib, you call code.
Oh yeah, you got to call code, because who's going to bring your crash cart? You're gonna be like, oh, I'm sorry, you're in VFib. Let me go get the crash cart so I can get the defibrillator. Your hands are on the patient doing CPR. You're going to call a code. That way somebody will bring in the crash cart and you can get the defibrillator. Do you understand?
Yes.
Okay. So we need to defib. We're doing CPR. And then what drugs are we going to give this patient? I'm not going to stop it. I need to calm it down. I need to calm down their heart.
Amiodarone.
We're going to give
Lidocaine.
amiodarone. Lidocaine is not considered drug of choice. Amiodarone
Well,
is.
amiodarone.
Okay. But the other issue is
Do you also do dopamine? No.
no. What we're going to do is you can do lidocaine. You can do amiodarone. That's weed for the heart, right? It's going to
Yes.
slow everything down. But the thing also you got to consider with VFib is it is going so fast that it can't contract. So we may give epi. And I know that sounds really messed up because epi increases your heart rate. But what we're trying to do is also increase contractility,
So
right?
why wouldn't you give dopamine or dobutamine?
Because you can't push it like that, right? Dopamine and dobutamine come on a drip,
Okay.
right? Epi you can push.
Okay.
And epi is also going to vasoconstrict. Since this patient had very little cardiac output, what do you think their blood pressure is probably going to look like? Low. So the epi would help with that as well. Okay. So you can give one of 3 drugs. Number 1, amiodarone. Number 2, lidocaine. Number 3, epinephrine. Okay. As soon as the patient goes into VFib, what are you immediately going to do?
Call code.
You're going to call a code and start CPR. As soon as the crash cart gets there, you're going to defibrillate that patient. Do you understand?
Yes.
Okay. Do you understand ventricular dysrhythmias?
Yes.
It's a great day.